Hi everyone, good morning. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. Today we're going to be discussing MDS and non-transplant therapies. If you're watching online, please feel free to submit your questions at any time using the engagement panel to your right. And type in your question and comment, hit enter, and we'll be going back and forth today between the questions in person and the questions online. I'd like to take this opportunity to thank all of our corporate sponsors and our patients and families for supporting the conference today. Our educational programs happen because of your generosity and paying it forward to be able to help others. I'd like to, at this time, introduce Dr. Paul Shami, who will be presenting today for us, and we thank him so very much for joining us today. He's doing inpatient rounds, but we really appreciate the fact that he was able to come over and join us today. Welcome, Dr. Shami. Thank you so much for coming today.
Thank you. Thank you for allowing me to talk. So, what I'm going to do is kind of give a background on myelodysplastic syndromes and go briefly over the way we approach these conditions, and then just basically leave it open for questions. So I would like to start by just very briefly go over a very simplified scheme of how our blood cells are made. So our blood cells, the white cells that fight infections, the red cells that carry oxygen, the platelets that prevent us from bleeding, all these cells are made in the bone marrow. The bone marrow, we have these so-called stem cells, which are kind of the mothers or the grandmothers of, or the ancestors of our blood cells. And these cells will divide, and then ultimately they will mature, change into our normal blood cells. And in a way, our white blood cells are kind of like the military with different branches. And so we have the two big branches, the myeloid branch and the lymphoid branch. And then these have smaller sub-branches. And that's how our blood is made. And so we end up having the different types of white blood cells that fight infections, and then the red cells that carry oxygen, and the platelets that prevent us from bleeding. This process where the cells go from an immature, so-called undifferentiated stem cell all the way to the normal mature blood cells is controlled by this molecule we call the DNA. And the DNA is essentially a code. It's like the app in your phone or the software in the computer. It tells the cell what to do. And every time a cell divides, it has to make a copy, an exact copy of that code into the next generation, and on and on and on. And so you can imagine that copying such a long, complicated code, cells can make mistakes. These are called mutations. There are special proteins like a spell check that correct those mistakes, and but sometimes they miss, and you could have enough of these mutations carried through generations of cells, so that basically messes up the way these cells mature normally and become our normal blood cells. And so that's what happens in myelodysplastic syndromes. We consider this to be a type of bone marrow cancer, and you have a population of cells that has built up these mutations, these mistakes in the DNA code. And if you have enough of those mutations, or if they're strategically located in the code, then you have this abnormal population of cells. We call them a clone because they all have a lot of the same mutations, the same mistakes in the code that take over the bone marrow. And so these cells are not very efficient. That clone is not very efficient at producing normal blood cells, and they prevent the normal bone marrow from functioning, and therefore the normal numbers fall. So we have the myelodysplastic syndrome manifested by mainly low blood numbers. You could have low red blood cells like anemia, low white blood cells, low platelets, or any combination of these low numbers. That's the main manifestation of myelodysplastic syndromes. That's why we call it also, it's kind of part of this big umbrella of bone marrow failure, because the normal bone marrow does not work properly because of that clone that has taken over the bone marrow. And depending on where the spectrum of these conditions is, the different types of DNA mutations and so forth, there's a more or less high risk of developing over time acute myeloid leukemia. That risk could be very high or very low or anywhere in between. And so the manifestations of myelodysplastic syndrome are mainly low blood counts with more or less high risk of developing acute myeloid leukemia. And it's a disease that is seen mainly in older patients. As we grow older, we are more and more likely to develop this condition, and it's mostly seen in patients who are older than 60. There's kind of a guess of about how many patients are diagnosed a year, probably more than 20,000 a year in the United States. I think a lot of those, there are a lot of patients who are not diagnosed with MDS because they have a mild anemia and their doctor just watches it without doing a full workup, which would not always be indicated. And so as we grow older, there are more and more cases of MDS, which frankly makes sense if you think about it. If we live long enough, our bone marrow cells have more opportunities to develop mistakes, to develop mutations that build up over time. So when our ancestors would die at 22 from a pneumonia, they would not live long enough to develop myelodysplastic syndrome. And the survival varies depending on the different subtypes of MDS we're dealing with, and we'll go over this in a minute here. So what do patients feel when, what causes the disease? In general, we don't know. We talked about these mutations, and these could happen just from living long enough. But there are certain known risk factors, like exposure to radiation, such as radiation for the treatment of another cancer, or radiation from working with radiation, or exposure to industrial radiation, depending on the job that one is involved in. Likewise, there are certain chemotherapy drugs that could be used to treat another cancer that could potentially cause enough of these mutations, enough of this damage to the DNA code to trigger the process or increase the risk of developing myelodysplastic syndrome. And then there are certain chemicals, industrial chemicals, like certain solvents that people could work with. An example is benzene, for example. All this could potentially increase the risk of developing myelodysplastic syndrome. So how do people present? How do they come to their doctor and say, there's something wrong here? Very frequently, people have no symptoms. If they have just a mild anemia, they're going about their life, they just go for their yearly physical, and their doctor gets a blood count, and they find a mild anemia. So frequently, MDS can go without any symptoms and potentially go undiagnosed because patients can be feeling well until their blood numbers fall to a clinically significant level. But in general, symptoms are related to how low the blood numbers are. So if someone is significantly anemic, like the red blood cells fall to significantly low levels, they could be feeling tired, unable to kind of go through their day without resting, short of breath, going up a flight of stairs. Then if the platelets are low enough, people could develop, bruising, bleeding, nosebleed, gum bleed when they brush their teeth. Something characteristic of very low platelet counts is what we call petechiae, which are kind of little red dots that you find on your skin. They're common around the ankles in patients who have very low platelet count. And then if the white blood cells are low enough, then that increases the risk of infections just because the immunity is weakened, and therefore people could start having infections related to their low white blood cell count. So when you go to your doctor and you're not feeling well, and then they refer you to a hematologist to kind of work it up a little bit more, find out what's going on. So what happens at the hematologist's office, in general, we take a very detailed history, exposures, etc., prior health, and do a complete physical exam. We obviously get the blood counts, we look at the blood cells under the microscope, what's called a blood smear, and then we check for any causes that could be easily fixed, that could be bringing down the blood counts, such as iron levels, vitamin deficiencies. And then we measure what's called the erythropoietin level. Erythropoietin is a hormone that is made in the kidneys that kind of helps the bone marrow produce red blood cells. That could be important to identify potentially causes of anemia and to also make some recommendations as to how to deal with the MDS. But the final diagnosis is usually made based on the bone marrow biopsy. So that's the procedure where, using special needles, we get a sample of the bone marrow and we do a lot of analysis on it in the lab. This includes what's called the morphology, where the pathologist looks at the cells under the microscope, and dysplasia means abnormal, so the cells could look, abnormal under the microscope. And then there's something called flow cytometry, which is running the cells from the bone marrow into the special machine called a flow cytometer to see if there are any abnormal cells there. And then very importantly, we mentioned these mutations, these mistakes in the DNA code of the cells, and so that's a very important test that we run on the bone marrow cells. Sometimes you can see very obvious mutations, something like we call translocations. Our DNA is packaged into these structures we call chromosomes. There are some MDS cases where you have missing chromosomes or spliced chromosomes, or there are some more subtle mutations, what we call point mutations. It's kind of like a letter or a typo in a letter in a code that is wrong. So all this put together gives us the diagnosis of myelodysplastic syndrome, and then depending on what all these tests show, we could kind of have different so-called prognostic scoring system that allow us to make some plans as to what we should do. And so this is the so-called classification of myelodysplastic syndromes. It's what's used most commonly is what we call the WHO, the World Health Organization classification, the one that, and it gets revised and updated every few years. So there was one revision in 2016, and then the most recent one was actually done last year. And you can see that myelodysplastic syndromes are not one condition, it's kind of a spectrum of different conditions. And a lot of it is based on the way the bone marrow looks like under the microscope, and then the type of chromosome DNA abnormalities that we find when we analyze the bone marrow. And potentially, ultimately, it could develop into acute myeloid leukemia. So we talked about prognostic scoring systems. So like in breast cancer or lung cancer, you have what's called a staging, stage 1, 2, 3, 4. In MDS, we don't have a staging system, but we have this so-called prognostic scoring system. This is one of the common ones that has been used. It's what's called the Revised International Prognostic Scoring System. And it is based on, the chromosome abnormalities, the big DNA abnormalities that we find in the bone marrow. It is based on the percentage of the so-called blasts. So the blasts are the very, very immature cells that we see in the bone marrow. If they are increased, that increases the risk of developing leukemia. And then it's also based on the extent of, how severe the blood count drops are. So how low the blood counts are, the red cells, the white cells, and the platelets. And that, to put this whole together, you can have 5 different levels of risk that range from very low to very high. So this is and the risk is basically the risk of developing, acute myeloid leukemia, with a so-called median survival that can range from, almost 10 years to less than a year without treatment. So this allows us to make recommendations to our patients as to whether we should treat the MDS and how to treat it. This scoring system has, again, been updated recently based on even more sophisticated testing, looking at, the more subtle DNA abnormalities, the so-called point mutations, and there's a number of them that get tested when we look at the bone marrow. And again, very similar to the older system, you have a range of risk from very low to very high risk of developing acute myeloid leukemia. And that gives us a statistical estimate of, the risk of leukemia, potential, survival without treatment, and so forth. And so, how do we deal with it? So in general, we have 2 very broad categories of patients based on these scoring systems that we just talked about. Patients who fall into what we would think would be a low risk of developing leukemia frequently, or sometimes we don't even need to treat them, we just watch them and they can go on with their life with just regular monitoring. But in that situation, if there's a need to treat, it usually depends on how significant the blood abnormalities are, like the anemia, the low red cells, low platelets, etc. We always try to enroll patients on a clinical trial if one is available, but sometimes patients need to be supported with transfusions. These could be very regular transfusions of red cells or platelets. One of the potential complications of red cell transfusions is too much iron in the body, and so there are ways of trying to decrease the iron levels, so-called iron chelation. These are special medicines that are used to try to decrease the level of iron that are accumulating in the body with every transfusion. Now, there's one subtype of MDS that has a very specific DNA abnormality, the so-called 5q-. It is usually associated with anemia. If that anemia is significant enough, there's a drug called lenalidomide that is very effective at reversing the anemia. The goal in all this is not necessarily to make the numbers go back up to normal, but at least to a level where the patient is not needing regular transfusions. Now, sometimes we talk about this hormone called erythropoietin, which again is made in the kidneys and help our bone marrow produce red blood cells. If the erythropoietin levels are below this threshold of 500 and a patient has a significant anemia, we can try to give them high doses of this hormone to, again, help the red bone marrow produce more red blood cells. aiming at just a level where the patient would not require regular transfusions. This could be supplemented with this other hormone shot called GCSF. There's a newer drug called luspatercept, which can also help the bone marrow in MDS patient produce more red blood cells. It works particularly well with a specific type of DNA mutation called SF3B1, or there's something called ring sideroblast, which is one of the things you can see under the microscope in MDS. So in this situation, the luspatercept can actually help the bone marrow produce more red blood cells. There are selected patients with MDS. Again, that's based on what the bone marrow looks like under the microscope and some other criteria where they could be treated in a totally different way using drugs that can suppress part of the immune system. This is called the ATG, antithymocyte globulin, and then another drug called cyclosporin, and then a third drug called eltrombopac. So this is a treatment that is very similar to what you would use in aplastic anemia. It works in very selected patients with MDS, so there's a subtype of or subgroup of MDS patients who could benefit from an aplastic anemia type of treatment. And then even its low risk MDS in some patients, again, selected patients in whom they have significantly low blood counts and everything else is not working, where we could try to treat with a gentle type of chemotherapy. And here we have two main drugs that can be used. One is called azacitidine, the other one is called decitabine, and then there's an oral formulation of the decitabine. But for low-risk MDS, the gentle chemotherapy I just mentioned is kind of reserved for, very few patients in general where everything else is not working. So that's the general management for patients who have low-risk MDS. We usually do not jump into chemotherapy and certainly not into a transplant in those patients. And as I mentioned, sometimes we just don't need to do anything, we just monitor it. The patients who fall into the high-risk category, these are patients who are, again, based on those scoring systems we mentioned, are at high risk of developing acute myeloid leukemia. And so, again, in a situation like this, if we have a clinical trial that is available, we try to enroll patients on such a trial. But that's when we try to treat those patients with some type of chemotherapy. In general, on the spectrum of chemotherapy, this is considered gentler, and it's the same drugs we mentioned, the azacitidine and the decitabine. However, if we can, if it's feasible, and you're going to hear more about it later on, in selected patients who have an available donor or otherwise in good physical condition or young enough, etc., a bone marrow transplant would be recommended if feasible, because that would give the patient the pretty much the best chance of ultimately having a long-term survival without developing leukemia. And so that's pretty much the summary I have about the non-transplant management of myelodysplastic syndromes, and I'd be happy to take questions. Yes, ma'am.
Do you know now I'm not knowing the exact how they say this, but it's a chemotherapy called hydro. Do you know the rest of it?
Oh, the hypomethylating agent?
I don't think that was it.
Okay, these drugs we mentioned, they belong to this family called hypomethylating agents.
Oh, maybe then.
Yeah.
Because we took one for a small period of time.
And oral hydroxyurea?
There was a pill.
Okay.
Oral. And hydro, yeah.
Yeah.
Hydro.
Hydroxyurea.
Yes, that's what it was.
Yeah. There is, what I talked about is kind of the general myelodysplastic syndrome. There's another group of conditions we call overlap syndromes, where patients have the myelodysplastic syndrome, but at the same time, their bone marrow produces too many of certain types of blood cells, usually certain types of white blood cells. So if the white blood cell gets to sometimes very high levels, that also could be dangerous. That's where, at least temporarily, you could use the hydroxyurea to bring down the white count to a safe level. So that may be what you're mentioning.
And that's what it did, yeah, it brought everything down.
Right, and it can bring everything down, but that's generally not what we use for all the MDS patients. It's more of a maybe a temporary measure to bring down the blood counts to a safe level so that the patient doesn't have significant complications from very high white counts.
So if you were taking I'm not going to say this right either, that luspatercept or whatever that is?
Or luspatercept?
Yes, if you were taking that, and then they gave you just the hydruria, however you say that, and then after you're off that, which was a very short period of time for us, then what happens if you don't get back on that luspatercept?
The luspatercept works in quite a few patients, especially the ones who have this mutation I mentioned. And when it works really well. There are 3 levels. We kind of move up the dose as needed. Unfortunately, it does not work forever. And so we keep using it until it stops working. And if we're in that situation where, we've done luspatercept, patient responded initially, is doing well for a while, and then we lose the response, there's not much as far as standard of care right now, approved drugs that have been shown to help with the anemia. Luspatercept is very specific to the anemia. So. And sometimes I mentioned this hormone erythropoietin to help stimulate the bone marrow, so that's another option. Usually we start with the erythropoietin, the hormone shots, to try to stimulate the bone marrow to produce red blood cells. And then if that doesn't work or we lose the response to that, the second drug we use is the luspatercept. But then if we reach a point where the luspatercept either doesn't work or stops working, then we don't have a standard of care drug to use at that point. Sometimes we use what I mentioned, these gentler chemotherapy drugs to help, control the MDS, to allow the normal bone marrow to start producing normal blood cells. But, yeah.
So if you put taking the sapropterin, whatever you say, and you're only taking transfusions, say 3 or 4 weeks apart, can you continue to just do the transfusion?
The answer is yes. I mean, theoretically, you can go on with transfusions in a unlimited, open-ended fashion. The problem with, like every 2 to 3 weeks red blood cell transfusions is, you get too much iron in the body. And there are ways to try to mitigate that with these so-called chelating agents. But there are, I've had patients who over their lifetime, from time of diagnosis to, when they pass away, have had hundreds of units of packed red blood cells to try to keep them where they can kind of have a reasonable quality of life. But theoretically, the answer is, as long as you're able to get transfusions, this is kind of an open-ended process. We use transfusions for as long as we can, while trying to mitigate the excess iron in the body.
So if you got the iron chelation, how often can you do that, or how often should you do that? Or is that just dependent on the iron?
Right. It depends on how high the iron levels are and how many units of red blood cells the patient has received. So there's that threshold where we start the chelation therapy. There are different chelating agents. The most convenient ones are the oral ones that are available, and we use them kind of on a daily basis. The patient takes that oral agent. There's like an injection or an infusion of a chelating agent. That's the older one, and sometimes this is the more cumbersome one to use because you have to use it every night and be hooked up to it. But sometimes what we do, we use an infusion of that chelating agent with each transfusion. So we give the transfusion, then we infuse the chelating agent. Again, it's kind of cumbersome because it takes more, 2, 3, 4 hours to infuse the chelating agent. Yes, sir.
My wife is sorry, she's here, she wasn't feeling well. She's a patient of Dr. Shami's, and she was on luspatercept and didn't do well. It didn't make any change, and he went to Invoken, and she's been on that for about 6 months.
Yeah.
Took her from a 5-day-a-week to 5 dosage down to 2 dosage because her neutrophils were slow in recovering. I'm wondering if you have any history or information about the Invoken and how that's working.
Yeah, that's the oral formulation of this cytarabine. It's, it can work. We adjust the dosage, as you know, based on side effect, mainly the blood counts. It could potentially work. Obviously, we have more experience with the azacitidine or the IV, the cytarabine, because these are older drugs. But it all depends on. It's kind of unpredictable in the sense we have to try it and see if it works, and then adjust the dosage depending on the response and side effects. Yeah. Yes, sir.
Should a person with MDS be taking a multivitamin with iron, or find another alternative? And question number two, what are the advantages of a clinical trial, and is hormone therapy included in that generally?
Yeah, the first question, should take an iron supplement or multivitamin supplement. In general, we would not recommend taking a supplement. The anemia of MDS is not due to iron deficiency, it's due to the bone marrow not producing enough red blood cells because of this MDS clone that's in the bone marrow. So iron or vitamins are not expected to make a huge difference. We also generally don't like to have our patients take supplements in general because sometimes these supplements, we don't know what's in them, the fillers and all that stuff. These could potentially affect, the bone marrow function. And then your second question was
about clinical trials.
Clinical trials, yeah.
You're speaking of it as an intervention, and I'm just wondering, is hormone treatment included in that generally, or what are the advantages of a clinical trial?
Yeah, as you can tell, this is an evolving field. We don't have perfect treatments for these conditions, and everything we do that we call standard of care actually was part of a clinical trial at some point. And so if a clinical trial is available, and it's a legitimate clinical trial, at the legitimate center, FDA, all the regulatory requirements are met. Frequently, that's the best option. If there's no alternative to treat the condition, or this could give access to a newer drug that would otherwise would not be available. That would be definitely the way to go. Like we talked about luspatercept, which was approved relatively recently, but it was approved based on clinical trials. So the patients who went on those luspatercept clinical trials had, access to the drug before anybody else. And of course, the trials helped many more patients afterwards when the drug was approved. So if it's a legitimate trial at a, well-established center with all the regulatory requirements, that would be, that's always a really good option. I wouldn't do things like, go somewhere and get snake venom or, that's not legitimate clinical trials. So.
Horse antibiotics.
Yeah, or, ozone therapy.
Clorox.
Yeah, Yes, ma'am.
I shouldn't say this, I've been taking a lot of homeopathic medications. I'm on no medications to take care of my MDS.
Yeah.
I've had bone marrow biopsies, a number of things, and they give me a bone marrow transplant. They say I have 1 to 2 years to live. And then I started my friends from India, and I started to Chicago. I started taking these medicines. And they came, you really don't need a bone marrow biopsy. And they asked me if I was taking blood transfusions because it was getting better. No, where would I get that? Somebody had to get those transfusions. And I know a lot of people do not like that, but it's working.
Okay.
And so I figure you do the best you can with what you've got. And I'm taking a number of homeopathic medications, vitamins, lots of vitamin C's, and all kinds of things that are working. But they're not like snake oil.
Right.
But I don't like to bring it up, but I have all the lists that my Huntsman, I've given them everything so they know what's in there, if there's going to be a problem and any treatments, but I haven't had any other treatments.
Yeah.
Because it was caused by my chemotherapy.
Uh-huh.
And it just all of a sudden, 2 years later, I came up with this thing. But I've got lots of energy. In fact, I'm going faster and walking faster than my students in Salt Lake Community College. Yeah, running. But I'm going, and I'm working, and I'm sorry. I feel very good about what I'm doing, but a lot of people it's not in the American Medical Association is not been testing this. Some of these, they're so there. I'm doing things that have got me really, I feel energetic, and I feel my mind is active, everything, all the things that they say. And they told me I had 1 to 2 years to live if I didn't get a bone marrow transplant. And then all of a sudden things are getting better.
Yeah.
And my blood, it was getting better. You know what I'm saying? What can I say? But I still, then my doctor tested me, you still have MDS. I said, thank you. Okay. I am aware of that.
Yeah.
But I won't interfere with the traditional medications, but there's no other treatments that I'm receiving right now.
Okay.
I just said that. I mean, maybe I'll be in trouble one time.
No, you won't, but.
You know, the fellow who was looking at wanted to do a bone marrow transplant said, "You're very young for your age." I'm like, oh.
Yeah.
I know. I'm happy to hear that.
And the
Just
thing
don't
about.
look at my face, I'm wrinkled.
Yeah. I mean, the thing about the survival, remember these are statistics, okay? So you have kind of the so-called median. There are people who live longer, live shorter than the median. And when people talk about median survival, that doesn't mean you take a calendar and you say, okay, I'm gonna die in 2 years or in a year. And so there's a wide range and I've had patients with like acute leukemia who beat the odds as far as, living much longer than the median just with supportive care in patients who didn't make it to the median statistics. So our challenge as, healthcare providers is you have the statistics, but we can't tell to each patient, Smith versus Jones versus Clark, on which part of that curve there will be.
It was such a surprise they have 1 to 2 years to live.
Yeah.
Okay.
Yeah.
Meanwhile.
Yeah.
Sorry. They didn't need to say that, now did they? I'm sorry.
Yes,
When I do my labs, what should I ask, because in State Health in Boise, they never test my iron.
I think if you're getting regular transfusions, it would be reasonable to test the iron levels, just make sure they're not too high. Yeah.
So what should I ask the doctor to, what kind of test?
Oh, it's called a ferritin level. Yeah.
Okay, thank you.
Yes, sir.
Thank you, Dr. Shami. We do have questions from online. I will start with one that says, what is your opinion about blood or liquid biopsies versus bone marrow biopsies?
Yeah, I know we want to avoid the bone marrow biopsy as much as possible because it's unpleasant, to say the least. Sometimes we can get some of those DNA mutation analyses done on the peripheral blood, but still, as of now, a very important component of evaluating the condition would be to look at the bone marrow, under the microscopes, which requires a bone marrow biopsy. The other thing is there's some of the chromosome abnormalities that we frequently identify in MDS. That test can be run on the blood, but it does not always work very well on blood. And so, as much as I hate saying that, the bone marrow biopsy is still an important part of making the diagnosis and, evaluating the severity of the disease. But hopefully at some point, maybe we'll get to a point where we don't need to do these procedures, but as of now, it is still an important component of what we need to do.
Thank you. I have a question about clinical trials. The patient says, how should a patient go about finding and enrolling in an appropriate clinical trial? It seems to depend largely on what medical center is hosting your treatment.
Yes, and so clinical trials there are some clinical trials that are open at multiple different cancer centers, some are open at very specific ones. In a way, it depends on which region you're in, but that's one where asking your hematologist about the availability of a clinical trial, if it's a physician in the community, they know the network they're in and they know the centers with whom they collaborate, or if it's a referral center, that too, it's always good to ask, are there any clinical trials available? There's a website called clinicaltrials.gov where you could look for, kind of search for a clinical trial. And then the other source of information also are the foundations like this one, where you could get information about clinical trials, the MDS Foundation, Leukemia Lymphoma Society. These, again, they frequently have information about which centers have clinical trials that are open for enrollment. Yeah.
Thank you. We also have a question from a patient who says, when would a change to luspatercept be done if procreate is seeming to not affect the rate of transfusions?
Yeah, so the procreate is this erythropoietin hormone, and one thing about it is the dose needs to be pushed to fairly high levels for it to work in MDS. So if it has been escalated to the highest appropriate level, and give it a chance, maybe a few weeks, maybe 2 to 3 months, and it's still not working, the transfusion requirements are still the same, then that would be an appropriate time to consider an alternative, and then luspatercept would be a potential one if appropriate.
The next question is coming from another patient who says, I had a bone marrow biopsy at the time of my diagnosis and have not had one since, and that was 4 years ago. How often should an MDS patient have a bone marrow biopsy?
Well, hopefully you will never have any other bone marrow biopsies. The only reason in my mind to get another one is if there's something that has changed substantially in the blood, okay? So if the blood numbers are getting worse, the anemia is getting worse, or a new blood number is starting, like the platelets, for example, are starting to fall. If there's a significant change, then that would be a reason to repeat the bone marrow biopsy, or like we look at the so-called blood smear, so the blood under the microscope when we see patients in the clinic. Even if the numbers look kind of stable, if we see something changing, like we start seeing, for example, blast cells in the bone, in the blood, then that may be an indication to repeat the bone marrow biopsy. But otherwise, if things are status quo and stable, I don't see a reason to get regular bone marrow biopsies.
The next question says, what are the signs and symptoms that MDS is now progressing to AML?
Yeah, that's a good question. It's all related to the extent of how the blood counts evolve. So if someone started to have more fatigue, that could be evidence of disease progression. Bleeding, bruising, that too could be evidence of disease progression. Acute leukemia sometimes can cause pain, like bone pain or joint pains. That too could be, evidence or an indication of disease progression, and or like recurrent fevers, that too could be. So anything that feels like the status quo is changing, like bleeding, bruising, unexplained fatigue, could be a reason to talk to your doctor and see if something has changed in the blood counts to warrant further investigation.
We also have a question about IPSSM and IPSSR. What is IPSSM? How is it different from the IPSSR?
Yeah, things have evolved over time as more knowledge, more investigations have been developed. The IPSS started as just IPSS, International Prognostic Scoring System, and then more data were developed, analysis of outcomes from literally thousands of patients, which led to the IPSSR, the Revised International Prognostic Scoring System, which became our standard for quite a few years. Now, the IPSSR, the Revised International Prognostic Scoring System, does not take into account the very subtle abnormalities in the DNA of the MDS cells. So what the analysis that is done to look at DNA abnormalities is what we call the karyotype, and there's also something called the FISH analysis. These look at very big abnormalities in the DNA that you could see under the microscope, like a chunk of chromosome missing or two chromosomes spliced together when they're not supposed to. That's called a translocation. This analysis is included in the IPSSR, but there are some abnormalities that you cannot see under the microscope that need more sophisticated, more sensitive testing, looking for very specific, like a typo in a letter, basically. And that's where the molecular IPSS comes into play. And this was a big improvement, actually, a big advance, because now, we have this test where we run this so-called mutation panel, where we're able to find these very, very subtle abnormalities in the DNA, which we can't see under the microscope. And now we have a scoring system that takes those into account, because those are important as far as, prognostication and all that.
Thank you. I have another question from a patient who says, why do platelet numbers vary so much during the course of the month with the days of treatment for 5 days once a month?
Yeah, so there's a low platelet count that's due to the disease itself, but there's also low blood counts that is a side effect of the treatment itself, okay? So call it kind of collateral damage. The azacitidine on the scale of chemotherapy that we use is rather gentle, but it can also affect the normal blood counts. And so that's why in between cycles, you give the 5 days or the 7 days of azacitidine, the normal numbers, the platelet count can fall, and then it recovers at around the time of the next cycle. And that's why we monitor blood counts in between cycles. And sometimes if we get a response, you get these kind of so-called nadirs, the dip, recovery, but frequently if the treatment is working, the recovery gets better and better with each cycle.
The next question says, I was diagnosed with MDS in 2022 and have no physical symptoms. Do I need to take the appropriate treatment that is being offered, or will the disease progress faster if I take no treatment?
Do I need to take treatment?
Yeah. Do they need to take Procrete that is being offered?
Procrete?
Yeah.
Okay. Yeah. Again, what we're talking about is this erythropoietin hormone that helps make the red blood cell, the bone marrow, or helps stimulate the bone marrow produce red blood cells. The erythropoietin hormone will not make the disease worse or better, in the sense it will not affect whether it's going to progress into acute leukemia or not. It will not change that risk. The goal of the erythropoietin hormone shots is to help the red blood cells go up to a level where the patient is not needing as many transfusions as before. So I think if your anemia is significant enough that you're needing transfusions and your doctor is recommending to try the erythropoietin, I think it would be reasonable to try these shots, see if you could decrease your transfusion requirements. But if, on the other hand, you don't want to take the erythropoietin, doesn't mean that you're going to have a high risk of developing acute leukemia.
Thank you. I also have a question from a patient who says, why do MDS treatments stop working? What is it?
That's a very good question, and I wish we knew. But, besides a transplant, which ultimately I'm going to hear more about transplant in a little bit, where ultimately what the transplant does, it replaces the diseased marrow with normal marrow. All the treatments that we have short of a transplant do not eliminate the abnormal clone, the MDS clone that is basically the problem. And over time, at least theoretically, you would expect that part of that clone will become resistant to whatever treatment we're doing. And so you have a subpopulation of this MDS clone that kind of develops and does not respond to the treatment. But yeah, that's kind of, it's not the $1 million question, it's the 10 billion, 100 billion, trillion dollar question.
We can all retire once we know how it happens.
Yeah.
I think this will be my last question. It says, it appears that Vidasa is no longer working for me. Are there other combination therapies I should consider before talking with the transplant team?
Yeah, if the azacitidine has worked for a while, which is great, at some point, unfortunately, it will stop working. In general, at that point, we don't have a standard of care where we say there's an FDA-approved drug that is, proven to work in second line. So that could be a time to talk with a transplant physician if appropriate, for your particular case, or maybe consider a clinical trial to see if there are any kind of experimental second line regimens that you could receive. Yeah.
Thank you so much, Dr. Shami, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on our conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in one of three ways. One, you can send an email to help@amds.org, or you could call the AMDSIF helpline at 800-747-2820, extension 2. Or you could also submit a question to our Facebook page at www.facebook.com/AAMDS. If you are watching online, please take a few minutes to complete the session survey. Your input is so important to us and will help us plan for future educational programming. Also, be sure to visit the exhibit hall and the chat with the conference sponsors. The next educational sessions will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure and diseases. The AMDSIF Medical Advisory Board and the team are here to help you and your family as we have for the last 40 years. This concludes our session.
Thank you.